Good morning. I'm Dr. Sarvesh. I'm here to present a case. It's about a 31-year-old male hailing from Chalakudi with complaints of fever, cough, and breathlessness. He was COVID negative. We are planning to. His saturation is low, so we are planning to give oxygen.
So he came with acute breathlessness. His saturation, you found that it is low.
Low, sir.
So we have to start oxygen before doing anything. Airway, breathing, circulation should be taken care.
Yes, sir.
Can we start oxygen?
Yes, sir.
Yes. Please start oxygen. So patient who is having breathlessness, important thing is put the patient in propped up position. Start him on oxygen. Okay. Rest all things we can take care. There should not be any desaturation. So he's an EMT. He'll start oxygen.
Okay,
now we can continue the presentation.
Okay, sir. History of presenting complaint. Patient was apparently asymptomatic 9 days back when she developed fever. It was a low-grade fever and was insidious on onset. It is continuous type and associated with chills and rigor. There is no diurnal variation and no aggravating or relieving factors. Patient also complains of cough for past 9 days. It was sudden in onset, continuous type. Initially, no expectoration was present, but it later became productive with yellow-colored mucoid sputum.
Okay.
Cough was more in the night. She also felt pain in the lower chest area while coughing. Cough was relieved on steam inhalation. There was no positional variation for cough, no associated nasal discharge, nasal block, or post-nasal drip. Patient also had breathing difficulty for 9 days, was insidious on onset and aggravated with cough. There was no relieving factors and no positional or diurnal variation. There was no history of headache, vomiting, hemoptysis, chest pain, orthopnea. Past history. Patient is a known case of bronchial asthma and is on inhaler for same. Diabetes for past 10 years and an oral hypoglycemic drugs. Hypertension and dyslipidemia for 8 years and on medications for it. No past history of CID, CKD, CLD, jaundice, TB. His personal history. He has mixed diet. Appetite is normal. Sleep is normal. Bowel and bladder movements are normal. No smoking or drinking. Family history. Mother is asthmatic. General examination. Patient is conscious, cooperative, well oriented to time, place and person. Well built and nourished. Height is 165 cm, weight 58 kg, BMI 21.3 kg per meter square. No pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. Vitals, pulse, rate was 80 per minute, rhythm regular. Condition of vessel walls normal, volume and normal, no radio-ephemeral or radio-radial delay. Other peripheral pulsation bilaterally palpable. Respiratory rate 24 per minute. Type thoracoabdominal. Temperature 97.3 Fahrenheit. Examination of respiratory system. Nose and nasal cavity are normal. Oropharynx normal. Examination of neck. JVP not elevated. Examination of lower respiratory tract. On inspection, trachea appears to be central. Apex beat was not visible. Chest is symmetrical, barrel shaped. Movements with respiration bilaterally equal but reduced. Use of accessory muscle of respiration present. No kyphoscoliosis, no drooping of shoulder. No supraclavicular hollowing or infraclavicular flattening. No intercostal indrawing. No sinus scars or dilated veins. On palpation, there was no no local rise of temperature or tenderness. Trachea was centered. Apex beat felt at the 5th left intercostal space 1 cm medial to midclavicular line. Chest movements bilaterally equal but reduced. Chest expansion 0.5 cm. His AP diameter to transverse diameter is 1:1, so we have barrel shaped chest. And vocal fermenters, all areas were normal. On percussion, resonant in all areas. Auscultation, air entry present in all areas. Vesicular breath sounds heard in all areas, normal. Intensity of breath sounds are normal. Wheeze heard in all areas, both right and left side. Crepitations heard in right and left infrascapular area, infraaxillary area. Vocal resonance was normal.
So we'll continue the treatment now. Because this patient has come with acute breathlessness. According to you, he had fever, some purulent sputum, but he is having history of asthma in the past. He was on inhalers. He also had diabetes. Okay. So how do you proceed with the treatment? We have started him on oxygen. That is not enough. You put the patient on bed, put the patient on propped up position. First response for any doctor is start him on oxygen. Okay. Because asthma is a condition where there is airway narrowing and low saturation, low oxygenation in the blood. So you have started oxygen. We talk about oxygenation. There is a difference between asthma and COPD in oxygenation. Which condition you give more oxygen? More oxygen is required in asthma, not in COPD. COPD should never try to target a saturation above 85 because they have continuously, chronically, they have hypercarbia and hypoxemia. If you wash out all the carbon dioxide, they will not breathe. Okay, that is a stimulant for them. Whereas in asthma is acutely
saturation.
Acutely is getting attacked. You have to keep the saturation above 95. So we have started. He is started on oxygen. He has improved in that part. Okay.
Then we'll have to give Salbutamol 0.5 ml 2 to 3 times nebulization.
So you can take the nebulizer, that is nebulizer. So he has mixed salbutamol. Okay, just pour it. Okay, that is enough. Okay, 2.5 ml taken and 2.5 ml, sorry, 0.5 ml salbutamol taken, 0.5 ml saline is also taken.
Yes,
so that is taken. Now we'll start the nebulization. Okay.
Okay, sir.
So he has started him on nebulization. What is the action of salbutamol? It is a bronchodilator. Okay. When you start a drug, you should know what is the action, what is the side effect of that drug.
Palpitations.
So patient can have palpitation, patient can have tremors. Then one more important electrolyte imbalance is hypokalemia. Hypokalemia is one of the most important side effect of salbutamol. How do hypokalemia affect the patient?
Paralytic ileus.
It is not. It will produce paralytic ileus, but in a patient with asthma, he is breathing with his respiratory muscles. Muscle require potassium. If you are giving continuously nebulization of salbutamol, potassium will come down in the blood. Okay, transiently it will come down. Patient will have more muscle fatigue. So when you are giving high dose of salbutamol, this can happen. 1 or 2 doses will not happen. Okay, so you are given 1 dose of salbutamol nebulization. It may take another 5 minutes. If the patient does not improve,
2 to 3 times.
You can give one more time. Again, you can give one more. Up to 3 times, you can give continuously. That may not create big problem. If it is very high dose, then patient can develop all the complications. So we have started him on nebulization. So we have started him on oxygen. We have started him on salbutamol nebulization. Then what is the next thing?
If it's not resolving, we can try leukotriene.
No, this is acute phase. Leukotriene modifiers are later in the ward. So you have started nebulization with salbutamol.
Ipratropium bromide.
Ipratropium bromide can be added to that. Ipratropium bromide acts in the smaller airways. Salbutamol acts in the larger airways. So these are the 2 important drugs. What else we can give?
LABA.
Steroid should be given. So what steroid you give?
Budesonide 200 microgram.
That is nebulization. We have to give IV or oral. So you give hydrocortisone 200 milligram IV. So you can give the IV. So you will give 200 milligram hydrocortisone for this patient who is having acute asthma. What is the action of steroid?
Bronchodilator.
It is not bronchodilator. It is an anti-inflammatory drug. So he has given an anti-inflammatory steroid now. Will it act now? It will not act now. It will prevent further episodes. Okay, steroid, it takes some action, time to act. Whether it is IV or oral, it takes time to act. So you give IV hydrocortisone 200 milligram. Along with this, you can start nebulization of budesonide. You are told budesonide. So we can give budesonide also, but IV or oral should be given. So we are given 200 milligram IV hydrocortisone. What else you have to give? You can try magnesium sulfate. Magnesium sulfate has got some bronchodilator actions and it can prevent repeated episodes. Okay. So what all we have given? We have started. We have put the patient on propped up position.
Oxygen was started.
Saturation was detected. It was low. We have started him on oxygen, high flow oxygen with mask. When we are giving mask, we have to give higher oxygen, more than 4 liters per minute you have to give. So that is started. High flow oxygen is started. Saturation is maintained. Then you start on nebulization. What nebulization? Salbutamol nebulization. Up to 3 cycles you can give. Then wait, because patient can have electrolyte imbalances or arrhythmias or palpitations. So wait for that. Nothing is there. You can even then also you can give. Then
magnesium
sulfate is given. Then steroids are given. If the patient does not improve with all these things, what else you do? Then you have another equipment, that is BiPAP. Okay, you should start the patient on BiPAP. If the patient is failed to all this treatment, failed to your initial treatment response, there is no response, then you can go for BiPAP ventilation. BiPAP is what is the action of BiPAP?
It
has got an inspiratory force and an expiratory force. Okay, so when you are inspiring, the ventilator will give some pressure and the air will go inside. When you are expiring out, it will put some pressure and it will not allow the air to go out fast. Okay, so inspiratory pressure and expiratory pressure we can set, and we can put the patient on BiPAP. Then once you do all these things, most of the patient respond to your initial treatment itself. Very rarely patient go to complications. Do you want to take an X-ray in this patient?
Yes, sir.
Yes or no? X-ray is required to rule out pneumothorax. Normally in asthma, X-ray will not show any finding.
No.
Whereas in COPD, you get pneumonia or infection finding. But in asthma, X-ray may not be required. But if the patient does not improve, then you will have to take an X-ray to rule out any pneumothorax, because pneumothorax also present same like this, breathlessness, acute breathlessness, desaturation. So X-ray is required to rule out complication, not for asthma. So you have taken an X-ray. Now the patient has improved with your initial treatment. What do you do?
Continue
nebulization 3 times daily. So you will be shifted to ward. From ward we have to discharge the patient. How do you discharge? What are drugs you give for during discharge?
LABA and
what is
short acting cord.
So first of
Salbutamol.
all, we will try that we take meter dose inhalers. So this is Salbutamol meter dose inhaler.
Okay,
so we were giving Salbutamol nebulization. This and that, there is no difference in action. Bioavailability, there is no difference. But the patient cannot carry that everywhere. So you give Salbutamol MDA meter dose inhaler to this patient for discharge. Okay. Yes, then we will discuss about other drugs. This is the simplest form of MDA, Salbutamol MDA. So this can be given, but if the patient is not cooperative or patient is not able to understand what you are telling, spacers should be given along with this. What is the difference between simple MDA and a MDA with a spacer?
If patient is not able to take the inhalation properly first time itself, we give spacer so that it will be comfortable for the patient.
So there is no need of coordination if you are giving a spacer. This requires a lot of coordination. So you take the puff, you shake it properly, take the puff and take a deep breath, hold it for some time, then expire. But if you have a spacer, nothing is required. Connect the spacer, spray it so that whenever patient feels to take air inside, he can take. Okay. So that is spacer and simple MDA. So simple MDA Asthalin we will be starting for this patient. But what is the difference between Asthalin or Asthalin is Salbutamol, Salmetrol, Formoterol, all these things.
Salbutamol is short acting. Salmetrol and Formoterol are long acting.
Okay. Salbutamol is a short acting drug. It acts for 6 hours. So you give every 6 hourly this Salbutamol. If you are giving Salmetrol, it's a long acting drug. So 2 times you can give. But what is the defect of Salmetrol? It will not act immediately. Somebody is having an acute attack. Salmetrol will not help. So you need Salbutamol along with that. But if you are giving Formoterol, Formoterol can be used as a continuous action, that is a preventive action, and it can be used as a rescue drug. So instead of giving Salbutamol with Salmetrol, Formoterol alone is enough. You can, in acute attacks, you can use the same drug. Okay. So Formoterol is the ideal drug. But asthma, you require steroid. Budesonide should be added to Formoterol. So Formoterol, budesonide will be an ideal combination when you are discharging this patient. Okay. So that Formoterol with budesonide 2 times we are giving. What else should be given along with this? You want to give Montelukast?
Yes, sir, Montelukast. Okay.
What is
Ziprolukast?
So you start him on Montelukast. So this patient require Formoterol with budesonide, BD dosages, and you give Montelukast. Okay. Ketotifen is an old drug, but still it is useful. But
Sodium
normally, normally we give Montelukast. You can give Montelukast. Then what else? What other things you should avoid? You advise the patient.
We should advise the patient to exercise daily.
What exercise he has to do? He can do 2 types of exercise. One is like respiratory exercise. he has to take a incentive spirometry, and he has to increase his lung capacity, and daily exercise also can be done. Some patients can have bronchial problem like breathing difficulty during exercise. That type of patients may require one rescue puff before exercise. Somebody is having breathing difficulty after running for half an hour. He should take one puff before running. Okay, that should be advised. So daily regular exercise can be done. Lung exercise also should be done. Okay, does he require any vaccination?
H1N1
vaccination. H1N1, COVID, all vaccination should be advised for the patient who is having respiratory problem. Should we give antibiotic for this patient?
Since cryptations is there, patient might have pneumonia.
If the patient is having pneumonia in X-ray, or if the counts are very high, or if the sputum contains some bacteria, culture positive, then only you require antibiotic. Most of the asthma episodes are inflammatory rather than infectious episode. So this patient may not require antibiotic, but since you told there is fever, there is purulent sputum, this patient may require antibiotic. What antibiotic you advise for this patient? Azithromycin is gram-positive coverage is there. So you can give azithromycin. Amoxicillin, clavulanic acid can be given. So always prefer to go for a gram-positive coverage in a patient who is having asthma with some infection. Most of the time, this infection can be viral also. So this patient may require oseltamivir or COVID treatment. Since COVID is negative, we are not talking about that. Oseltamivir is used for H1N1. Okay, so these are the important things you should do for a patient who is having asthma. So most important is taking this MDI properly. That is very, very important. The patient does not take MDIs, he can have exacerbation. Okay, so formoterol is the ideal drug, should be given for a patient who is having asthma. It can be given as both rescue drug and preventive drug. That is very, very important. Okay. Okay.
Thank you.
Thank you.